When I ask my students, where does stigma come from? The most common answer I get is the media. But does the media actually bear the blame? And if so, how? Well, there's no question that the media is an influencer of society. But it's also important for us to recognize that the media is influenced by or responds to society. The media is, after all, in the business of selling its newspapers, its television programs, the advertising spaces on the news. And if the newspapers aren't being sold, then they wouldn't be printed the way that they're being printed. So when we pick up a newspaper, we're silently voting for the content and the way that that content is presented. If we want the media to change the way it presents itself, history shows us that we have to do that by telling the media what we like to read, what we like to see, and so forth. The other thing we have to remember is that the media is not just one universal thing. We talk about the media, we often refer to it meaning the news media. But in fact, there's entertainment media such as movies, television programs, and even the video games that your children play, as well as educational media, things like school books, as well as educational games. And obviously, sometimes the media is actually sending positive or informative messages. And if we want the media to change the way that it informs the people, we need to make sure that we are subscribing to those media outlets and those media formats that are doing the constructive work. So let's take a look for a moment at some of the things that should give us some insight into how the media can influence us. First is just in the question of what gets covered entirely on its own. What stories are getting discussed? I think it's safe to say that today's newspapers still have a high degree of things that are scandalous or titillating or sensational. Violence, crime, sexuality. Any of those sorts of things are more likely to get into the newspaper than, for example, good news stories. And if those stories happen to also have a valent of mental illness, then that's also going to be brought into the fray. The negative thing, of course, about this is that people begin to assume that whenever they're reading stories about violence and mental illness is coming into the question, that mental illness and violence become associated in people's minds. Prominence of the coverage is another way that we can look at influence from the media. We haven't even gotten into what the content of the story is or the way it's written, but now we're just talking about where is it actually in terms of the newspaper or in terms of the television news broadcast. For example, in the news, is it on in the first 10 to 15 minutes, which is when most people would tune in. And because of that, where most people would assume the story was most important. In the newspaper, is it on the front or the first few pages as opposed to tucked in the back? And is it presented in a prominent way? For example, how much airtime or page space does it get? Is it given bold type, large headlines and photographs and so forth that help it to be more eye-catching? Who's actually presenting it? Is it some newscaster who is prominent, or is it somebody who is a small sort of unknown outlet? And unfortunately, a lot of times we get a sense of how important a story is by how many media trucks are parked around outside. So the more that it's covered by different news programs, the more it's likely to get also prominent coverage, the more likely it's going to get put on the front page. What language is used? Sometimes the language is actually pretty bold. For example, in the articles that you were reading here, you might have noticed that in the Gordie Howe article, they used the word horrors of dementia. In the article about NASA and astronauts and psychosis, they used the word unglued. And in the case of the Demi Moore article, they referred to a treatment facility as lockdown. These are examples of words being used in a prominent media source, and often people assume that if it's written, it must be okay, and that therefore allows people to begin to use those words themselves. In the article about the judge in the Hartford Courant, you might have wondered, why is this article included in the package? It seems to have absolutely nothing to do with mental illness. Well, when it uses the word schizophrenic to describe a job that has essentially a split personality requirement, they're really, if you think about it, communicating to people not just about the nature of that judge's job, but also they're telling people how the word schizophrenic should be defined and used. And so while the person may not immediately walk away with a negative impact mentally about people with schizophrenia, they may begin to use that word in a way that continues a long-standing misconception of what it really means. Think about the images that are used. In the article on Evil Dare Speak Its Name, Depravity Scale Proposed, you'll notice that the image that's used is not an image of the doctor spoken about in the article. Instead, it's an image of a serial killer. Ask yourself why we would do that. Why would an article about a doctor proposing a method for the courts to use to assess people with psychopathic tendencies have a picture of somebody who isn't recently being tried or isn't a part of the doctor's study? And in fact, you probably will arrive at the same conclusion as I, which is that it simply grabs the person's eye. You're more likely to recognize this story as prominent because there's a photograph of a well-known serial killer. By the way, going back to the subject of prominence, that particular article was printed in the National Post, which is one of Canada's national daily newspapers. And yet, if you look closely at the article, you might wonder why it's there. It's about the United States court system, and in fact, it wasn't only printed in the National Post, it was printed on the front page. So asking ourselves, why is this covered and why is this prominent, as well as the images used and the language used? And this particular article should stand out to us. Words like evil and depravity to describe mental illness. Even if it is criminal mental illness, we can probably make a distinction between a person who's mentally ill and a person who's evil, but this article wouldn't suggest that. And what's the content? What actually makes it into the article? For example, who gets interviewed? Is it only the crime victim? Is it the police? Or did somebody actually interview a mental health professional? Did somebody interview the family of the mental health professional or of the individual themselves that might have been the mental health consumer who is at the heart of the story? So we want to think about what gets in and what doesn't get in. In the story about Demi Moore, there were a number of issues. We can talk about, for example, the fact that it was a story that made itself fairly prominently displayed in the newspaper. Its coverage was quite broad. It was a syndicated story published in the Vancouver province, but it originated from a syndicate in the United States and is distributed throughout the world. The language, as we mentioned, is not particularly flattering, referring to Demi Moore's treatment as lockdown. The image they chose may be stirring to you because it's not a glamour image of Demi Moore. It's not what we're typically seeing. Instead, they show her looking somewhat haggard and rushed in front of a nondescript brick building. And the very fact that they identify it, if you look closely, as a piece of health news as opposed to celebrity gossip should also concern us. Look at the story more carefully again. Who gets interviewed? Unidentified sources or who we're listening to. Nothing is actually quoted from Demi Moore or from people who are willing to go on the record as saying that they're close to Demi Moore, and there's certainly nothing there from a mental health professional. And yet, the story is presented as health news. We also need to make a distinction about whether what we're reading is an article or a piece of opinion. Oftentimes, people make that mistake. And I see it myself as a person who often writes columns. People come up to me and they say, "Oh, I enjoyed your article." And I often have to remind people, actually, that wasn't an article. I wasn't being a journalist. I was being a columnist. And those are two very different jobs. Journalists have to abide by an ethical underpinning to be as objective as possible, whereas columnists wouldn't be columnists if they weren't being asked to present opinions. Now, hopefully, they're responsible in backing up their opinions, but frankly, that hope is often not substantiated. And the columnist's job is often to provoke, to create people getting emotional or thoughtful. But that doesn't necessarily always mean that they're getting as emotional and thoughtful in balance. Sometimes people are walking away from those feeling a strong feeling, but not necessarily questioning what they've just read. So we need to make a distinction between opinion and journalism. And even when we're reading a journalistic approach to things, even when we're reading a news article, we need to ask ourselves, is the journalist telling us what they believe, or are they quoting what somebody else believes? For example, in the article on depravity and the evil scale, the author of the article is not saying that he or she supports this 22-level rating scale, but they're quoting a doctor who says that. And that doctor is one person. We have no idea after reading that article whether or not this is a broadly accepted concept. It might be a flyer, one person's idea, and it dies within the next few months. But because of its prominence, because it's covered in the first place, and because of the fact that the content gives a great deal of space to this one doctor and not to others who might disagree with him, at the end of the day, we might walk away thinking the journalist supported or promoted that particular perspective. We also need to think about, as I said earlier, the fact that sometimes the media gives us positive information, but it doesn't always do it in a way that's palatable or accessible. For example, in the article on Gordie Howe, the story, in a manner of speaking, is positive because it helps us become more aware of dementia, more perhaps empathic of people going through dementia. But at the same time, people reading that article have reported to me that they sometimes felt it was perhaps a bit too sensationalized, too sympathetic as opposed to empathetic. And in some ways they were disturbed by this. And I can see their point when, for example, the author talks about things like the horrors of dementia. And another example is the article about the drug program. When we look at that article, it's largely an educational article. Chances are you couldn't find much in it that was objectionable. Now, you may not agree specifically with the concept that they're talking about in terms of using psychoactive drugs to help treat people with addiction issues, but that's not the point. In terms of the article being written in an objective and informed way, it probably has done that fairly well. But take a look at where that article comes from. It comes from a small online publication called Drug Policy News. Chances are the only people who would likely access this article are people who were already informed about, to some extent, addiction and recovery, people like yourselves. It isn't in the mass media and is unlikely as a result to have a positive influence on social attitudes. So even when an article is well written, it may not have a positive influence because it simply isn't getting out to the public. I also asked you to think about, how does stigma affect mental health? One of the things we need to think about is, if a person is stigmatized, they may be less likely to go and access care. And the studies on this are remarkable. The numbers sometimes vary, but in some cases, as little as 1 in 10 people are saying that they would go and get help if they were diagnosed. Because going and getting help means acknowledging that one has a mental illness, and that means acknowledging that something is wrong with them or something socially unacceptable is going on in their life. Like most illnesses, if people don't get help early on, their chances of recovery are significantly reduced. When a person has early intervention, they're far more likely to successfully recover. But many people, because of stigma, delay getting help until their symptoms cannot be ignored or until other people refer them for help, often by calling first responders such as yourselves, because things have reached a crisis point. Stigma can also affect whether or not people go to their families. We heard earlier in this very module about people of Asian descent being reluctant to go to their families. But it's not only true in Asian families. And even in cases where people do go to their family, their friends, or to their community, sometimes they are met with disapprobation or alienation. In other words, often it backfires for them. So people, because of stigma, may actually lose an asset that they very critically need in a time when they're seeking recovery. Because as we said a few slides ago, social connections are incredibly important in terms of maintaining our welfare and in terms of actually putting in place care plans. Stigma can affect our ability to get or keep our job. If people that we work with believe that our diagnosis makes us less confident or somewhat frightening or unpredictable, then our job may be in jeopardy, especially if we need to take leave or take time away from work to address our mental health needs. For example, it's considerably more socially acceptable to take a day off because of an acute bout of the flu than it would be, for example, to take off a day because they were having a particularly acute bout of anxiety. And so job security is unfortunately threatened as a result of stigmatization of mental health. And this, of course, has an impact on people's income, which downstream can put them in a category of below the poverty line, as discussed earlier. The other thing we need to remember is that if a person has been stigmatized, then often downstream from that stigmatization of mental illness is the stigmatization of the treatment methodologies that would be used. Medication is probably the worst of these. And so many people have preconceived notions that taking medications is bad. Medications must be bad because they're associated with mental illness. And doing things that are about maintaining my mental health, like for example, going to a counselor, attending group sessions and therapy sessions, are difficult for people often through the lens of stigma because they feel that doing those things is a constant reminder that they don't fit in or that their social value is diminished. All of these things can have an impact on people's relapse and recovery rates. If one doesn't feel as though one can freely identify supports, follow their care plan, and access the help that they need, they're more likely to have relapses in their mental health. In other words, to experience crisis. And their recovery rates are less likely to be there as well. We're more likely to see people struggling to recover. Stigma also affects you and I in some very concrete ways. There are financial costs. The cost of having a person living on the streets is significantly impacting. A few years ago, when George W. Bush was the President of the United States, he actually began a program of aggressively trying to reduce homelessness. And he hired a gentleman who was titled or well known as the homelessness czar. And what he did is he went around and he spoke to community groups in the United States and Canada trying to promote programs that would reduce homelessness. The interesting part of the story is that he often spoke to business improvement associations and chambers of commerce, not to social service agencies or police agencies or mental health agencies. And the reason that he did this is because he often wanted to make to people the business case for forwarding homelessness programs and initiatives. In other words, he was trying to make it clear to people that business people would be wise to support programs that addressed homelessness because in the end, it actually costs them less. For example, if there are homeless people on the street where you're doing business, often, rightly or wrongly, the public perceives that the area is not as savory or as safe, and this impacts whether or not they're likely to patronize your business. But there are also direct costs, not just lost opportunities. For example, the cost of policing as a way of helping people is extremely inefficient. The police often are only able, as you know if you are a police officer, to address things from a stopgap approach. They're there during crisis, and largely that's all. They need to have the support services so the person stops going through that care repeatedly. So the policing numbers are affected by the numbers of people on the street with mental illness. Correctional facilities often become inappropriate, but the only choice for facilities to house people with struggling with mental illness as well. People have recurrent medical costs because they go and access care at the acute level, the local ER, as opposed to going to their primary care provider and having care provided at a far lower cost and not creating long waits in emergency rooms, not making it so that emergency rooms need to have additional staffing. And the social assistance costs are huge as well, because if people are helped early on and they're given habilitative services that help them to get and maintain jobs, then they need less in the way of income assistance as well. We also see something that I call neighborhood atrophy. The fabric of a neighborhood can start to decline as people struggling with mental illness sometimes are supported. And this isn't a very politically correct thing to say in some people's cases, but as a person who's been a long-time provider of social services, I have to tell you that one of the things that was an important criteria for me when selecting a location was that it was central, but that it wasn't central along with a whole bunch of other services. I wanted there to be a mixture in any area in the community, any neighborhood where I was putting a location of a service agency. And the reason was I didn't want to ghettoize a neighborhood. I didn't want to stigmatize the neighborhood as being a place just for people who are struggling with social needs, and not a place where commerce or recreation or leisure could take place. In other words, it needs to be a mixed, diverse, and healthy neighborhood so that everybody is benefiting. We need people who are doing well to be associating with people who aren't doing as well, because those are often the social connections that are most important as resources. And it also helps in terms of building community will. If people feel as though there's a good fit between a social agency and a commercial area, then everybody seems to get along. But if we start to tip the scales and have too many social agencies all in one area, it can make for a great deal of user conflict in the neighborhood. So we need to find a way to have balance. But we also need to do some education. I don't want to be a Pollyanna about this. I've experienced it directly, where even when I was careful to locate a facility or an agency in a place that I thought was not going to do that ghettoization, there still were times when neighbors were confrontational or were very resistant. And in those cases, I needed really to do some marketing work and some consultation and collaboration with the neighborhood. Doing things like signing good neighbor agreements and having people become exposed directly to the people we'll be supporting instead of me being the one speaking for them were a couple of very simple things I did to help decrease some of that stigma effect. Homelessness can also be a cost because if people who are stigmatized don't feel like they can go and get care, then they end up having poverty, homelessness occurs, and that's when you and I go out and we start to experience interactions with people that can sometimes feel overwhelming. I don't know about you, but when I go out in the street, even as a very experienced mental health and social services practitioner, I find sometimes I don't know what to do with that individual. I met a man last December, in one of the coldest days of the year, sitting on a downtown Vancouver street with only a pair of pants on. No shirt, no socks, no hat, no jacket. Well, I couldn't begin to tell you what I would do for that individual. I was a visitor in that particular city. I didn't know the services in that area, had no relationship with that individual. It's overwhelming to imagine what one can do in that particular circumstance. And we need to realize that homelessness impacts us in lots of ways, including in terms of our moral fiber. My son said to me, "Dad, I really don't like to go to Vancouver right now." And he's a 7-year-old boy. And I said, "Why?" He said, "Dad, it's really hard to be on the streets with people who are homeless." And what he meant by that was it breaks his heart. He finds it hard to see that every day and not feel like he can do anything about it. And this is a 7-year-old boy. So if it's affecting him this way, it's affecting all of us this way. It's evidence to us that there's something wrong with our society every time we see it. We also know that there are many people struggling with mental illness who are, as a result of not feeling like they can access proper services, engaging in self-medication. That means that they are often providing a market for the drug seller, the drug producer. And in turn, people often are engaged in illicit or criminal activity in order to feed their drug habits. So by allowing people to be out on the street dealing with mental illness issues, instead of making them feel like they are welcome to come and live in neighborhoods or access services in neighborhoods, which could actually help them in the long term, we're actually making these crime problems worse. And as I said earlier, what does it do for our feeling of safety and comfort in our neighborhood if we're walking around and we see people who are not being taken care of? It should make us feel disturbed. It should make us feel, there but for the grace of God go I. So there are financial costs, moral costs, and quality of life costs for all of us if we allow stigma to be a predominant force in the way our society treats mentally ill people. How does stigma affect mental health? Well, I want you to do me a favor and click on the link that's in the slide, but it's also going to be on the Moodle page, and you can click on it from there because this link won't work for the people watching this on YouTube. So I want you to watch all 6 chapters of Stacy's story, which is a story about a teenage girl, and ask yourself, is Stacy's story common? Review the article that's also attached for further insight. It's from the Nursing Times. It's in Australia, and it's about the effects on stigma. It will also be on Moodle for you to read. Stigma is not just a byproduct of the media information or even the other sources of information that we receive. It's also a byproduct of the way our minds work, and in particular of some mental processes referred to as cognitive biases. These cognitive biases have begun to gather some steam lately in terms of public prominence. For example, in his book Blink, Malcolm Gladwell talks all about the way that we reach quick decisions, or the sort of mental processes that we use. And in his book, My Life as an Experiment, A.J. Jacobs dedicates a very illuminating and amusing chapter to the approach he's taken to an experiment where he tries to live his life without these biases and finds out that they are often as constructive as they are damaging. Because cognitive biases are basically mental shortcuts. They are cross-cultural and universal ways our minds work. So they occur in every society, and they occur in every person, and they are a way for us to basically create mental shortcuts. They're patterns of thinking. Often they're a product of things that we've thought of many times in our life, and our brain doesn't feel a need to go through the same lengthy flow chart. Instead, kind of directly gets to the punch. And this is very much connected to our survival. For example, if I said to you, you were in a back alley with somebody who was bigger than you, walking directly at you at a quick pace, and carrying something shiny in their hands, my guess is that you would probably try to get yourself away from that person, and that you wouldn't spend a lot of time standing there waiting to find out more information. My guess is that you wouldn't expect the individuals coming up to you to ask for directions. And that's because you're using a long-standing approach of quick thinking or cognitive biases that basically say, I'm going to assume that this is a situation that's dangerous, and if I'm wrong, it's better to have a false positive than to be caught wanting in that moment. We are especially vulnerable to these cognitive biases if we perceive that we're in some sort of a crisis, if it's a dangerous or urgent situation. Cognitive biases affect people on both sides of the interaction. So the helper can walk into a situation with determined thoughts, but so can the consumer. For example, if a consumer walks in and they see somebody wearing a suit and tie, they may have brought with them a cognitive bias about how that person is going to respond to them. A person wearing a suit and tie, after all, is very formal, don't you know, and is probably not going to be as approachable and reasonable. So you can imagine how those cognitive biases work in both directions. Being aware of our biases, fortunately, is one way for us to actually reduce the effect that they have on us, the negative effect on us. So it's as simple as being more aware of them, and that's why we want to talk about them in the next slide. So here's some of the common perceptual biases that are out there. The first one's called the availability bias. And what it basically says is, the more I hear about something, the more it's in the news, for example, the more it must be common. In other words, if I can see it, it must be common. And in fact, this is what happens. The statistics show that most people in Canada perceive that the rate of violent crime is going up, when in actual fact, the rate of violent crime is going down over the last 30 years. But the amount of reportage, the amount of space given it to violent crime in the news media is going up. We have more 24-hour news stations and radio stations that cover the news all the time, and many of us are exposed to these messages frequently. What does that do? It makes us think that they happen more commonly. Unfortunately, that's actually the opposite of the truth. The truth is, something is more likely to have prominence in a newspaper if it's unusual or rare, but our mind doesn't perceive it that way. Another bias is what we call the confirmation bias. And what it says is, I tend to see only evidence that supports my preconceptions. If we have an opinion, the more strongly we hold that opinion, the more likely we are only to hear the views of other people who agree with us. Imagine sitting, for example, at a public hearing and standing and speaking at the microphone on your view. When others get up and speak, we listen with keen ears to when people are saying things that support our view, but we may tune out people who disagree with us. At the end of the day, the effect of this is that we walk away more certain of our view than ever. Another effect is called the bandwagon effect. And it simply says, if other people are saying the same thing as me, then it must be true. The more people who believe it, the more it must be true. And it's simply not an accurate perception, but it's one that we cleave to all the time. The media uses it quite frequently in things like advertising, telling us, that it's the best-selling car in the world. So we think to ourselves it must be the best car in the world, when in fact it might just be the cheapest car or the best marketed car. The fourth one we wanted to talk about is attitude polarization. And you can see how it works very closely with our second one, confirmation bias. The two of them go closely together. Attitude polarization is a very curious one, because we might assume that when people go out and do research, they actually are more likely to be balanced in what they learn. But the truth of the matter is that the more research people do, often the more certain they are that they are right and that the other person is wrong. In other words, they often only seek out research that confirms what they believe. So this goes closely with the confirmation bias, and people become more polarized in their attitude and less likely to hear what other people have to say. What I'd like you to do in your journal, and this is going to take you a little bit of time, is a little bit of homework on stigma. In your journal, think about ways that you and others where you work might inadvertently spread or strengthen a stigmatizing view of mental illness or addiction. So have a conversation with people where you work, including people who aren't taking this course. Could be over coffee, could be at a staff meeting, but we want you to get people thinking about this. What are some ways that you could help to reduce stigmatization where you work and in the community? And it's not lost on me that the answer to the second question is to some extent by having the conversation in the first question. And finally, discuss your thoughts in class or in the blog with a partner, whatever works for you in each of those ways. What ideas did they contribute to question number 2, or did your colleagues contribute? And we're hoping that you come up with some concrete things. For example, perhaps there's opportunities for training where you work, or perhaps there's language that you can clean up in your written policies or in the way you speak every day. Perhaps there are ways to give consumers more prominence in orienting staff or having people or having a role in determining the face of that organization. Those are just 3 examples. We want you to think, how can you combat stigma? Discuss the issue at home, at work, and in the community. And we think it's especially important that you do that with young people and when adding people to your team. Make it part of your orientation process. Be a role model yourself. If you're walking around making jokes about mental health, then chances are people are going to give you less credibility if you start to raise it as an issue. Speak up when others perpetuate stigmatizing behavior. Now, I'm not asking you to be confrontational or to put yourself in a situation of conflict, but be the voice of reason when other people are asking questions or, making statements that might be a bit damning. Ask questions. Encourage people to connect with resources that might give them some realities. Think about what you do in the training where you work and what the policy looks like. Are there ways to fix it and improve it? Be involved as a volunteer in your community. Look for ways to include mental health consumers in their own care or in being advocates for mental health. Be an advocate yourself. Endorse resources that you have learned from, perhaps this course or a book, video, or other piece of media that you know is working effectively. And connect with other people, other healthcare providers, social service providers, and help people with mental health needs to connect with those same folks and with each other as well. So those are just a few of the ways that you might combat stigma.